15-minute video lesson is to help undergraduates to improve their skills in the clinical examination of the cardiovascular system. Here I focus on the technique and not on individual physical signs or their interpretation. Cardiovascular examination is divided into several components. We start by doing a relevant general examination, then we proceed on to the examination of the pulse, blood pressure, the neck, and lastly the precordium. Precordial examination is also in two parts, palpation and then auscultation. This is Sarath, who has kindly volunteered to help us today. Thank you very much for coming today, Sarath. We approach the patient from the right side, and the preferred position for the examination is at 45 degrees. As you approach the patient, you take a wide angle look. See whether the patient is comfortable, whether the patient is breathless, whether there is pallor or cyanosis. Then you get close to the patient. You start by examining the head and the neck. Look at the conjunctiva for pallor. Look around the eyelid for xanthelasma. Sarath diwa දාන්න. Look at the tongue for central cyanosis. කට හොඳට අරින්න. And inside the mouth for septic teeth. Cut. Look at the precordium. Look for left thoracotomy scar. Look for any sternotomy scars and look for any bulging of the precordium. Then you pick up the hands. There are a lot of information one can get from inspection of the hands. Look for any nicotine stains, vasculitic lesions, splinter hemorrhages, and then look for clubbing. When you look for clubbing, you should hold the finger at your eye level. You compare with your own finger and compare the angle. The earliest sign of clubbing is loss of this angle. There are several degrees of clubbing. The earliest stage of clubbing is loss of the angle. In later stages, there will be increased curvature, and in very late stages, the whole distal phalanx will be like a drumstick. Now, in infective endocarditis, clubbing is usually mild. If there is gross clubbing and cyanosis, that indicates the presence of congenital cyanotic heart disease. Then focus your attention on the feet and look for knee ankle edema. Sarath මම මේසෙක් ගලවනවා. Okay, apply firm pressure just above the medial malleolus and hold it there for a few seconds. Then take your finger out and see whether there is pitting. If the patient has been in bed for some time, it is possible that there is no edema at the ankle, but all the edema fluid is collected over the sacrum. In that case, you will have to ask the patient to sit up and then look for pitting edema over the sacrum. You start examination of the pulse by first palpating the radial artery. First you count the pulse and then check whether the pulse is regular or not. Then pay attention to the character. I would like to refer you to Hutchison's clinical methods to learn about different characters of the pulse. Also check whether the pulse volume is normal, low volume or high volume. If the pulse volume is high and if the pulse is bounding, you have to look for a collapsing pulse. Before you check for the collapsing pulse, you ask the patient whether there is any problem with the shoulder joint. Sarath, මොකද අමාරුවක් තියෙනවද මෙතන? රිදිල්ලක් එහෙම? නැහැ. Hold the ball of your left palm on the radial pulse and then lift it high in air. Support the arm with your right hand. If there is collapse impulse, you will feel that bound impulse both with your left hand and with your right hand. Sometimes the character of the pulse is better appreciated on the brachial pulse or over the carotid. Then you end the examination of the pulses by checking all the other pulses, both carotids, සරත් මේ පැත්තට බලනවා. Other radial pulse, and pedal pulses. මේ shock එක ගලවනවා. Dorsalis pedis, and then posterior tibials. If the patient is hypertensive, you have to look for the radiofemoral delay. In the examination of the neck, you concentrate on the pulsations. If there are any pulsations, you have to find out whether they are arterial or venous. Venous pulsations are in the posterior triangle. They have a definite upper margin. They have a sinuous waveform that moves with respiration, and venous pulses can be easily obliterated by applying light pressure. Once you find the JVP or the jugular venous pressure, you have to get the upper level. You do it by measuring the vertical height. First you draw a horizontal like this, and then measure the vertical height from the angle of Louis. In addition to getting the height of the jugular venous pressure, you have to see whether there are any abnormal waveforms. Again, I would like to refer you to Hutchison's clinical methods to learn about abnormal venous pulsations. Prominent arterial pulsations are called Corrigan's sign, and that is a sign of several cardiac problems including aortic regurgitation and hyperdynamic circulation. Measurement of the blood pressure is an integral part of the cardiovascular examination. There are a few important points I want to stress. When you apply the cuff, it should be over the brachial artery. There should be at least 1 inch gap above the cubital fossa. And when you wrap it up, make sure that there are no wrinkles. There is a separate video on measurement of the blood pressure, and I would like to refer you to that video.